Hi, everybody. I'm Paulo Soares. I'm hematologist here in Brasilia. And here we have honor to speak with Dr. Pagel. And Dr. Pagel is a hematologist in the United States, and he has a lot of knowledge about CLL. And he's joined us now to talk about the new evidence that is coming in the nearest ASCO meeting. Dr. Pagel, thank you to have your time with us. Can you introduce yourself and talk to us what are expectations in the next ASCO meeting now in 2020?
Yeah, great. Nice to be with you, Paulo, and nice to be with all of my friends there in Brazil. Many of you I've been lucky enough to get to know over a short time. I'm John Pagel. I'm in Seattle, Washington in the United States, and I'm a CLL physician and researcher. And I have really had an exciting opportunity over the last many years to be involved in the therapies that we are really using that have been game changers for CLL patients, paradigm shifts, and of course that's around targeted therapies. And it's very exciting that at the upcoming meetings of ASCO, as well as the European Hematology Association meeting, we have data that we've been waiting for a long time, and you're not going to want to miss this data. It's around two major studies. The frontline Elevate-TN trial that used acalabrutinib either with or without obinutuzumab that was compared to chlorambucil and obinutuzumab. Now we have longer 4-year follow-up data of that trial, and the safety profile is very consistent, and it's important to see that people can do well on this therapy for prolonged periods of time without significant toxicity. But I think the most exciting thing that we've been waiting for is the Elevate-RR study, which randomized high-risk relapsed CLL patients to ibrutinib or acalabrutinib. It was a non-inferiority trial. We know the data from the press release that showed it was a positive study, meaning that there was at least as good efficacy with acalabrutinib, if not better, but certainly absolutely not worse. The efficacy of acalabrutinib in that study was outstanding. But most importantly, the side effect profile is dramatically different between the different agents. And we see that at least in the early data suggesting that the rates of atrial fibrillation are dramatically less with acalabrutinib than with ibrutinib. And we'll learn a lot more about the other side effects and potential differences. You're going to want to look for that data coming out of ASCO here very shortly, because it's going to be very important when we think about which Bruton tyrosine kinase inhibitor we want to use for patients as we move forward.
That's great. It's not every day you have a head-to-head comparison. Sometimes you're tied to a situation, you have to compare crosstalk arms of different studies, and now you have this head-to-head comparison. Can you elaborate more about the efficacy? In the second generation of the BTK inhibitors, we expect the same efficacy of the first generation, or have some trend for superiority? What do you think?
It's an important point. Remember that these early BTK inhibitors are what we call covalent binding irreversible inhibitors of Bruton tyrosine kinase. And the first generation ibrutinib, second generation drugs such as acalabrutinib or even zanubrutinib, which is just starting to emerge on the horizon for CLL, they all interact with the same amino acid binding sites in the pocket of BTK. So their efficacy is not surprisingly very similar. In fact, we expect it to be very similar, if not almost exactly the same. And that's what we do see in the Elevate-RR relapse refractory trial. And you're absolutely right. It's not often that we get a head-to-head trial, and that's why this is so exciting. But the differentiating point is not going to be the efficacy. We wouldn't expect that, to come back to your question. The differentiating factor between first generation or now second generation BTK inhibitors is the safety profile of the drugs.
Yeah. Do you think that all the safety profile, the better safety profile for the second generation is due to the off-target effect, the less off-target effect of this second generation?
Well, what we're going to see is that I think a very big difference between the side effects between the different agents. And we have to assume that there's a significant reason for that. And we do know that there are many more off-target kinases that ibrutinib interacts with where acalabrutinib doesn't. In fact, if you look at those that interact at least at a significant level, there are very few with acalabrutinib compared to many with ibrutinib. And I think that's the biggest reason we will likely, and we anticipate that there will be very big differences in the safety profile. And I think that most importantly, at the end of the day, at least for me, where I have a lot of experience with all of these drugs, is consistent with my and many others' clinical experience. It's due to the off-target kinases interacted with between the different agents.
And for last, do you think this better safety profile will keep patients using the drug, and they're going to see a better PFS in the long term, better overall survival in the long term, just because more patients are keeping using the drug?
Absolutely. Just remember, discontinuation rates due to ibrutinib are on the order of at least 25%. The longer you can stay on therapy, the better you're going to do. I think we're going to be able to see that with acalabrutinib.
That's perfect, Dr. Pagel. Thank you. Thank you for all your insights. You've seen ASCO.
Nice seeing you.